Hello, everyone, and welcome to today's training, Cultural Consideration for Addressing Mental Health Issues in Hispanic and Latino Children and Youth. This event is for the Ventura County Office of Education. Our presenter for today is Dr. J. Rocky Romero. Dr. Romero is the CEO and owner of the G.R. Romero and Associates, a training and consultant company he started almost 20 years ago. Dr. Romero is a former assistant professor for the New Mexico Highlands University School of Social Work in Albuquerque, New Mexico. He served as the co-chair for Governor Richardson appointed New Mexico Higher Education Department on Cultural Competency Task Force. Dr. Romero has also served as an executive council member for the New Mexico Consortium for Behavioral Health Training and Research, to include other boards and committees. He completed his doctoral studies at the University of New Mexico in Language, Literacy, and Sociocultural Studies, with a focus on analyzing legal discourse through a critical race lens theory. Dr. Romero has been a trainer and consultant for the National Hispanic and Latino Mental Health Technology Transfer Center for the past 10 years and a national trainer for Claire Matrix, formerly known as Matrix Institute, for the past 12 years. He is focused on culturally appropriate treatment while focusing on reducing health disparities for people of color. Lastly, Dr. Romero is focused on the intersection of racism, discrimination, and the impact of racialized legal discourse on people of color. Please remember that the National Hispanic MATTC network uses affirming, respectful, and recovery-oriented languages in all activities. Prior to start, we will do the poll question. We will take you back to Cindy.
Thank you, Christina. Good afternoon, everybody, and welcome. Our first pretest question reads, the level of acculturation served only as a risk factor for mental health among Latino youth. It's a true or false question. (43% said true, 57% said false. Next question says, increasing protective factors in the community can reduce mental health conditions and substance use disorders among youth. Once again, true or false? And 100% said true, 0% said false. Our last question says, Latino youth that present risk factors have a chance to experience more risk factors and lower protective factors. Once again, true or false? And 97% said true, 3% said false. That was our last question. So without further ado, I'm going to leave you with Dr. Romero.
Thank you, Cindy and Dr. Miranda. I appreciate the introduction and the welcome, and hello to everybody out in Ventura County. We're coming to you from Albuquerque, New Mexico, so I'm glad to join you all. I want to just kind of touch a little bit on this slide before we move forward, but really looking at how the language that we use and really making sure that we're aware of how that impacts people of color and young Latino youth, I think is really important as we start this presentation. I also want to just start by saying, thank you to Daisy for organizing all this and getting us set up, and of course to Dr. Miranda and Cindy for helping us get all of everything organized on the logistical side of things. I'm excited to be with you all for the start of our three-part series, and really looking forward to hearing from you all as well as as you're able to give us some feedback. I think it's really important to hear from you all and let us know how we can help and cover material specifically in the next in the next 3 sessions that we have. So for today, what we're going to do is look at some trends in mental health disorders, including suicidal thoughts and behaviors, especially for the Latino youth population. We're going to discuss specific cultural specific risk and protective factors associated with mental health, and then identify ways in which language use can improve mental health among youth. And then lastly, there's about 3 or 4 slides that I wanted to introduce as we start to get towards next week's presentation, that'll look at how we start to think about restorative justice and all that implies, and all of that work that goes into creating an atmosphere and an environment that is conducive to that. So the disparities that we look at, we definitely see the Hispanic children and adolescents are at significant risk, and there's many factors that we'll speak about today to give you an idea of how to, one, do a really thorough intake and assessment to be able to assess these issues at an early time and intervene early into the case. So about 33.7% of Hispanic students experience persistent feelings of sadness or hopelessness. And I'll share some data a little bit later also with regard to, one of our local, data sets that really looks at hopelessness and despair as variables for potential suicidality and, of course, other leading to other mental health disorders. We see Latino and Hispanic youth and children more likely to have initiated alcohol use or cigarette use in the past year. And this is all coming from the Centers for Disease Control and Prevention, are half as likely than white adolescents to use antidepressants. So we don't see a whole lot, but it is starting to become more prevalent, the use of over-the-counter and prescribed medications relative to substance use disorders. Are half as likely as white children to use stimulants to treat disorders such as attention deficit and ADD. We still kind of think when we look at this, the Latino youth communities, there's not a whole lot of deviation from the general population. So I just want to make sure that we don't, and I don't send the message that we should, pathologize young Latino youth either, right? We shouldn't come into this thinking, okay, this is a huge percentage, where some of the numbers are, a little higher. And I think we know some of those reasons, but I think the other piece to this is understanding that many times these are reactive symptoms to trauma or to other situations that potentially, if we get an early handle on, we can alleviate hopefully some of the long-term mental health disorders or substance use disorders. So the biggest key to this slide, I think, that we need to take away again is looking at it from the access to healthcare and access to mental health. And when we talk about disparities, obviously that being, or those two being two of the majors when we talk about access to increased trauma and other experiences through immigration and other things, but then also that exacerbated when we talk about some of the events that are going on in our society today. And I think those are things that we have to really speak about honestly and openly when it comes to young Latino, Hispanic, and youth, given some of the inequality and racism that we see. So this inequality puts them at higher risk for more severe and persistent conditions, as we said. And then as a community, we definitely see trends that point to Latinos being less likely to seek out mental health treatment. Usually they'll stay within the family, a comadre, a compadre, a family friend, you know, someone that is close to them in age but maybe older, that may serve as a parental role to adults, and then young kiddos, we see them seeking out peers, and sometimes peers that may not be the most or the best influence for them in a vulnerable state, as we know. So some of the, you know, the common health disorders that we see among Latinos, and what we're going to do is give you some more specific, you know, appropriate terminology when we talk about idioms of distress relative to the Hispanic and Latino populations. But you know, in general, we look at the same disorders that most young people are experiencing in pretty high numbers: generalized anxiety disorder, depressive disorder. The depressive disorder that we see here typically has a element of suicidality, and that's the part that we want to really kind of point out today, which I'm sure those of you that are on this training may see some of those things going on in your communities, and especially in different parts of California with immigration and all the other things that go on that we see. So post-traumatic stress disorder or substance use disorders. Some of the symptoms of depression include unusual sadness or irritability, and again, these are very similar symptoms, if not identical, to other racial groups. But we start to see some of that shift and change just a little bit in terms of more, I think, more pronounced physiological symptomatology, where a kiddo will report headaches and stomach aches. And when we talk about inequality, I think sometimes it's hard for young people to pinpoint what that feeling is of them being othered in a school or in a community or in a community-based agency, or othered within their own family, right? When we talk about some of the inequalities and inequities. Hold on one second, I'm sorry. So the depressive symptoms, again, that we look at: unusual sadness, a loss of interest in activities that they once enjoyed, reduced feelings of anticipation, maybe changes in weight and physiological appearance, shifts in sleep patterns, sluggishness, harsh self-assessment: I'm ugly, I'm no good, I'll never make friends. So some of that, you know, really self-defeating language, and really trying to understand what messages they're sending to themselves is a big piece to this, as you all know that are experts working in this field. Feelings of worthlessness and hopelessness, and then thoughts of or attempt at suicide. Now, what we know, though, again, if you kind of just look at those symptoms without having the overarching Latino or Hispanic, you know, kind of description of these symptoms, you know, you could really look at these very similar to other populations. So we have to say that I think more is evident when you start to develop the relationship with the young person and really start to be aware of how you come into that relationships. And we'll talk about that in just a little bit. Again, you know, sometimes when there's persistent depression or persistent symptoms that are noted above, at times those may pertain or persist and point to, you know, depression, and we definitely have to screen for that as we talked about. Anxiety or symptoms of anxiety include trouble sleeping, complaints about stomach aches, again, physical problems, right? Stomach ache, headache, pain that they can't really describe, maybe an achiness overall, avoidance of situations. And again, we have to be cautious because teenagers most often are like that at times, right? Where they avoid situations. So it has to be very pronounced, and maybe looking back at the history of this young person, is the behavior that they display typically one that is avoidant or alone, or you know, a loner, as we say. Or are they exhibiting clingy behavior around parents or caregivers when typically they've been much more relative to, you know, being kind of free and you know, looking and stretching boundaries and moving away from such close parent contact. But again, I think those are all relative to young people's normal developmental stages as well. And then we look at trouble focusing in class, disruptive behavior, explosive outbursts, and overly self-conscious. Again, which are pretty common symptoms for most adolescents, but these may be exacerbated and more persistent. And again, we have to look at that relative to a young person's behaviors prior to, if you have that comparison data and collateral information. Now, one thing that I want to say about anxiety that's not included here is that we have to understand how important it is for us to be aware of the technology and the use of social media and that sort of thing that may also exacerbate anxiety, right? Where a kiddo is using their smartphone and laptops or iPads and constantly having that stimulus. Again, research shows that can persistently cause young people to have anxiety, not be able to sleep, and have insomnia because the brain is still working long past the time that the child puts the tool down, right? The smartphone or the iPad or whatever technology they may be using. Now, this is significant, and this is a really important data also when we look at it from my community in New Mexico. So I think we also have to look at suicide as kind of a regional experience when we look at the United States and ask the questions of why is it affecting and impacting young people, usually young people of color, at a much higher rate. And again, when we look at it comparatively to other populations and take that into account as well. According to 2017 Youth Risk Resiliency, and this was administered by the Centers for Disease Control, ages 10 to 24, 1 out of 10 Latinas attempted suicide in the past year, 2 out of 10 made a suicide plan, and half said they felt hopeless. That's one of the data sets that we also saw in New Mexico that was very significant, and it was relative to the Youth Risk and Resiliency Study, also of 2017, that noted that access to guns has a very significant impact on the means and the method that young people are carrying out suicide and taking their life by suicide. So we have to really understand that. And then what are we uncovering? And we have to understand what are these feelings of helplessness. And now what I would say that this is old data to a degree, 2017. However, it's the most current. I think they're releasing another set here really soon. But that tells us that this does not take into consideration the impact that the current societal issues that young people are seeing and witnessing and visualizing and replaying in their brain over and over again with the civil discourse that we see, racism and inequities and things that are being pointed out in our communities, and the way that our leadership at a national level talks about young people of color, right? And we'll look at some of that more down the line here in just a little bit. Some of the warning signs of suicide include, again, isolation from friends and family, problems eating or sleeping, mood swings, reckless behavior, dropping grades. I think there's always an important piece that again, some of the data that I think needs to be included in some of this research is the social media part, right? A lot of the research that's been done at a national level for suicide as well really points to the fact that young people start to withdraw from their social media accounts, and they start to slow down in Twitter and Facebook and all these other social media outlets that they're a part of. Research and that data shows that contact with those and that communication starts to fade away roughly 48 hours or so before young people actually take their life by suicide. So we have to just pay attention to those things as well. Some of the symptoms that we see on the right-hand side here, on the right-hand column: increased use of alcohol or drugs, giving away belongings, talking about feeling hopeless or trapped. We also have to talk about, the importance of us asking a young person if they are feeling suicidal. Are they having thoughts of suicide? We have to be comfortable being very direct and honest and open about that question, knowing that research shows that those questions don't increase the potential of a young person taking their life by suicide by us asking if they are and really examining that in a deep way. If they are talking about suicide, or of course, if you find writing or suicide drawings, or acting out in play, you definitely want to intervene and ask some important questions, and really ask your parents to take a look at that. But we see, here in 2017 compared to 99 females, a pretty significant spike, especially when we look at the range of 10 to 19. So, these data points here that we see on the left, with the orange being the 2017 data, you see, and this is at a rate of 100,000, situations of suicide, obviously reviewed by the Center for Disease Control and Prevention. So we see significance in that, right? Again, a 2% increase and 3% when we're looking at it from the statistical significance. Those are significant increases, and we have to just be aware of how the data that is, again, 2017, where do we see this spike now if we were to point out 2020 as well, with some of the current situations that are happening in the community. Suicide trends in Hispanic by age group. Again, suffocating is the dark green, poisoning light green, firearms gray, and other light gray. So we see females much more through suffocation and poisoning, where males, almost half, 44%, use firearms. So when we're doing assessments of homes, I know those are tough questions, especially with some families that may be very private, or not wanting to cause any red flags to come up, especially if there's any sort of legal history within the home. Their disclosure of access to firearms, may not be the most transparent, and I think it's important that we ask that, and maybe even when we get that gut feeling, we provide them with the resources to safely lock their weapons if they do have some, or provide them with other information, and or some local departments, police departments, give out gun locks, and sometimes those are effective ways to just kind of think about prevention when we look at these slides. And then, of course, with 57% of females suffocating, and suffocating can be a number of different things. The primary method that I would say from this data would be of hanging. And we have to be aware of that, obviously, in terms of when we ask about the means from a young person. Sometimes we don't think of a lot of different things that can create suffocation. And sometimes we have to safeguard that and really ask some of those questions. So now we start to see kind of this comparison with female to male, and the female being the dotted line at the top, male in terms of suicidal ideation, we see that being the gray line again. So there's a significant difference statistically that we have to really pay attention to. And when we talk about the means, we also have to talk about the effectiveness of their use of those means, right? Meaning that who are more successful in terms of carrying out suicide plans, and typically we see a lot of that pointing more to males because they use typically more lethal means, and the data points to that, right, when we talk about weapons. The risk factors relative to protective factors. Now, part of what we also have to see is that we have to be coming from my undergrad and graduate work in terms of strength-based perspective, right? I definitely think that if we look hard enough, we can increase the right side of protective factors. But some of the risk factors that we see: mental health disorders or symptoms of depression and anxiety, minimal or no sense of family connectedness. And we're going to see a lot of this, folks, and unfortunately with some of the decisions of our government recently, where most recent indications in articles that have shown over 500 kids have been disconnected from their families and don't know where their parents are currently. I think we're going to see that in different pockets of the United States if we're not already. And not that that is a new trend. We definitely see different immigration patterns also from certain populations that come to the United States, and at times will immigrate separately and rejoin at times that they're able to. Acculturation is definitely something we have to talk about, meaning that when someone immigrates to this country, they start to acculturate to the United States culture. When we talk about dress and talk and style and use of social media and all these other things that we see in terms of adolescent behaviors. We have to know also that young people will acculturate usually at a much faster rate than their parents or their grandparents, right? Because of their access to social interaction, their access to social media, usually access to smartphones, computers, all that stuff. Cultural dissonance, or the feeling of an uncomfortable sense of discord, disharmony, or confusion. And again, this is all part of the adjustment aspect of immigration, but not only immigration, but adolescence, right? Either childhood to adolescence or adolescence to adulthood. People are experiencing these different changes during this time of, 8 to 24 or 25 years old, and really looking at some of those changes is a part of our assessment that we really need to focus on and take stock of. And then again, the migration experience or immigration experience definitely is something we have to consider. Now, another part of this that I want to make sure of, I'm sorry, let me go back. The protective factor. So access to effective and culturally appropriate mental health and behavioral health care is definitely a protective factor. Family connectedness and support. So family is a very broad definition, right? This can be extended family. This can also be surrogate or extended. So we have to just understand that piece as well, especially when it comes to the Latino and Hispanic family dynamic and kind of makeup. We definitely see an increase in protection and keeping kids engaged through physical activity. Of course, sports activities is one example, but not a lot of kids are inclined to go into sports. So think about different sorts of social supports, maybe just a place to hang out, a place for them to do their homework. We recently created a drop-in center, I didn't create it, but in Albuquerque that really focuses on just giving young people space to hang out, and it has a little kitchen set up for them. And this is what we see is a lot of the young people who are experiencing homelessness or in transition are going into this space, and they have a kitchenette where they allow young people to make themselves meals, and there's just someone supervising. They have resources available if the young person wants that, but if they don't, there's more of just a prevention atmosphere. We have to look at the experience of adverse childhood experiences when we're talking about young Latino children and youth. And that comes in many different forms, from traumatic experiences and events to abuse and neglect, maybe living with an adult, a parent, grandparent, aunt, or uncle who has a mental illness and or substance use disorder. We see children of different races and ethnicities do not experience ACEs or adverse childhood experiences equally. Nationally, 61% of Black non-Hispanic children and 51% of Hispanic children experience at least one ACE compared to that of their counterparts, 40% of white non-Hispanic children and 23% of Asian non-Hispanic children. And we see a big impact from that relative to immigration, and also we see, I think, that more prevalent nowadays when we're looking at people's experience with just society and some of the social inequities and racism and discrimination that young people are also experiencing, that sometimes we don't take as serious, right? I think now we're coming to a place where people are being more aware of asking those questions. Have you experienced racism, and giving them a definition? Have you experienced discrimination? What does that look like for you? How did you experience it? What did it feel like? Validating that for young people can be a significant shift in their anxiety and a significant shift in their connectedness and therapeutic alliance with you, the school, and or again, community-based agency that you may be serving. So again, we have all these different impacts, and it's really significant. If 4 or more ACEs, then 2 times more likely to be obese, on top of when we look at Hispanic and Latino youth, that's already another factor that many young Latinos experience as well already. So this may be on top of that, right? 2.5 times more likely to smoke, 10 times more likely to use IV drugs, 32.6 times more likely to be diagnosed with a learning or behavior problem, 4.5 times more likely to have depression, and then very significantly we see 12 times more likely to have suicidal thoughts or actions. And this is significant, folks. The 6 or more ACEs can cut your life short by 20 years. 20 years, right? So when we talk about the impact and the opportunity that you all have when you have young people in front of you from Latino and Hispanic backgrounds or young people of color, you have an opportunity to intervene so that they don't experience any more ACEs, and that we get a chance to really impact that by some of the strategies that you'll see in just a little bit. So we see this regionally, right, and which is really, really awesome with this slide by Saxon and Murphy. So regionally, looking at California, and let's kind of stay in this area, the Pacific area, obviously we see Black and Asian at 26 and 4, other non-Hispanic, white Hispanic, 16 and 22, and then Hispanic at 17. For the mountain regions of New Mexico, Hispanic at 28%. Oh, I'm sorry, I'm reading the slide below, which is the Pacific Islands. United States, top left corner, my apologies. The Hispanic 21% there you see in yellow, and compared to the mountain regions of New Mexico, Utah, Colorado, 28%. So relatively, and then we get in the high far east coast here in New England, right? That's the other area that we see significant impacts to the Hispanic populations compared to other parts of the United States, and then including down in Florida and in the Keys area. So it's just important to kind of get a sense of these ranges of ACEs and experiences. And again, these are 2 or more, right? So we'll see kind of what some of those impacts may be long term here in just a little bit, and how we can impact those. So when we look at ACEs, economic hardship, parental divorce, experience discrimination, these are some of the reasons why a young person may experience an ACE, right, or what's defined as an ACE. And I'm sure many of you know this data and ACEs, and I may be preaching to the choir, but I really want to just share, when we look at this compared to U.S. native versus families that have immigrated versus the whole group, we definitely see immigrant families being impacted at a pretty significant rate. However, when we look at parental divorce, right, or alcohol and drug use, in those areas we are actually a little bit lower. So overall, I think those are pointing to different factors relative to family and seeing family when there's low divorce rates and families are staying together. And that might be a lower number because of reporting, but maybe something to build on when we talk about protective factors. And it fits, obviously, the information we're sharing with you that we'll talk about here in just a little bit. So we know that each one of these areas may be impacted by adverse childhood experiences if we are not early intervening early. So injury, mental health impact, maternal health for young women, infectious disease, chronic disease, risky behavior taking, and then of course the lack of opportunities for education. And I think we have to really, not just for young Latino and Hispanic youth, but for all youth, right? I think we have to get away from this. And I don't want to sound negative, but this American dream of every young person is going to go to college and experience that. And the truth of the matter is not just the Hispanic and Latino populations, but other racial groups of youth and teens and adolescents we should also promote the skills that they can develop through other vocational trades, right, that they may have a very high success rate at. And not to say that we shouldn't push young people of color to try to go to school, but let's be realistic also and really set our expectations and help them achieve the wants that they have desires to. But I'm totally about setting the bar high, right, and high expectations, because I know our young people can achieve those things. I've seen it, and I'm glad to set those high expectations as well. So ACEs can be prevented by strengthening economic supports, helping young people's moms and dads and grandparents or aunts and uncles get a better job, help them to increase their awareness and hireability skills through doing different support groups at your agency or at your school, like resume building, interviewing skills. Have them go practice some interviewing with you or one of your social workers at your school. Promoting social norms that protect against violence and adversity, ensuring the strong start for children, teaching skills again to help parents through not only parenting but also through acquisition of new skills, connecting youth to caring adults, and intervening to lessen immediate, of course, and long-term experiences. So now we start to look at the risk factors. And we definitely see that studies show that people that present risk factors have a chance to experience more risk factors and lower protective factors. And I think we had a really good response to that one. So you guys are knowledgeable in this area, right? So when we're talking risk and protective, we definitely have to look at the individual, relational, communal, and societal levels of risk and protective factors. At an individual, are there language barriers? Are there low educational or financial status? Is there an experience with mental health and substance use on the individual, or again, when we talk about familial and relational, acculturation stress, acculturation gaps, aspects of intergenerational conflicts, what that means for folks that may not have a clear understanding, intergenerational conflicts or acculturation gaps. Acculturation gaps, are the gaps that I mentioned earlier between a let's say grandparents' generation or parents' generation compared to their child or their grandchild's generation, right? So really understanding that there's gaps in between those relative to acculturation, and then there may be, based on that, intergenerational conflicts that are created, right? The young child is advancing at a much rapid rate, learning a ton of information all at once, all these different messages and images that they soak up through access to social media, right? Impacts that development much more rapidly than it does their parents or their grandparents. So that, to me, is what we want you all to focus on. Now, those intergenerational conflicts change developmentally, right? But for this presentation, we're looking at specifically with adolescents and youth or young kids. The role of acculturation is, and I know one of my colleagues is going to, I believe, give you all, those of you that have signed up for the acculturation piece, a much more thorough description. So we'll touch base on this just to kind of give you a primer for that. Acculturation can be protective and or risk factor in mental health services, right? We definitely need to consider the intersection of multiple factors related to acculturation. And acculturation can also mean that at what level is the person's family immigrating and during and in the immigration process, if that is the experience that they're reporting to you. And it obviously can impact adolescent life experiences. So acculturation strategies should be integrative. I think we should work towards assimilation to a degree, but again, that's at the pace of the client. We shouldn't force assimilation, and for many communities, assimilation can be a very negative or charged or political word that's used. So be aware of that. Address separation if there's young people here that you're working with and families are still in the immigration process, maybe en route to the United States or still in their home country. Investigate that. Definitely call out and be aware of marginalization, right? Marginalization, when young people are being marginalized or pushed to the fringes of society or othered or discriminated against, can definitely impact acculturation. Biculturalism, this is also the conflicts we see when a young person is kind of straddling two cultures, right? Their American culture and their culture of their home country. And sometimes those two don't line up, and a lot of times they don't. So trying to reconcile that in some way definitely is appropriate. And then, of course, other cultures, when we talk about if you have a young person that is a part of the LGBTQ community, right? If you have a young person that's a part of other communities relative to their social experience and connections, really be aware of that as well, right? In the community, we look at stereotype gender roles, and we're going to look at more specifically when we look at Latino Hispanic families in just a bit, really understanding disparities in service and understanding social determinants of health when we're talking about access to schools, access to healthcare, access to a safe community and environment. That's what we're talking about when we're looking at social determinants of health and wealth many times, right? When we talk about that part of a young person's long-term kind of trajectory as an adult. And I'm looking at time here. Just so that everybody's on the same page, we have about 25 minutes, I'd say, with regard to the presentation, and then I would be more than willing to engage and talk about any questions that you may have. And I'll also provide my email to you all, and you can email me if that would be more appropriate. Mental health protective factors, traditional gender roles. Now, we have to honestly say that there can be negative connotations or experience with each of these as well, right? For instance, machismo in some cultures and in some communities, and I would say more with individuals within those groups, you see individuals taking machismo to a very abusive or overly controlling type of role. But it can also be a very protective role. It can be a role of a provider, demonstrating strength, self-reliance, control, right? That's in contradiction to the previous description I gave you, right? Someone that is possessive, someone that is overbearing, someone that is wanting to be controlling but isn't involved in the parenting, and or is maybe potentially there's domestic violence involved. So we've seen machismo also take on a different sort of role, but in this case it can be definitely seen, and we have to assess for that as a protective factor. Marianismo is the expectation that females will take on a Virgin Mary-like demeanor or role of a caretaker, demonstrating purity, care, family, privacy, and morality, right? So really in many cultures and communities, I think you have to also look at patriarchy and matriarchy, and those are very similar concepts to this, for the fact that some indigenous communities that may be very, very connected or interconnected, like we are here in New Mexico, to our native brothers and sisters, and there's communities that are intertwined. Some of those communities take on more of a matriarchal kind of approach, where the mother is actually the kind of lead in terms of family decision makings and really leading that family. Being the team leader of the family, so to speak, to use a George Lopez joke, right? But we also see that in communities, we do see the patriarchal system, and that's more of the dominant community and society that we see in our communities, which I'm sure is pretty similar to your area out in California. We definitely have to look at how this impacts perceptions of what a Virgin Mary kind of complex can create for young women as well. Family and spiritual machismo pillars may be protective against depressive symptoms and promote academic resilience, and that's a positive protective factor, right? But we've also seen young women who don't feel that they meet that or aren't living up to that maybe we have to help them in that cultural appropriate treatment that we're providing, and that we're, through this and other trainings, you'll learn how to do that be more aware of that, and pay attention to that. And that kind of points to our second bullet, right? Virtuous or chastity in terms of subordinate to others, or self-silencing pillars are purported to be negative of Marianismo, really meaning that can create depression, or academic outcomes among Latino adolescents. And again, that goes back to this feeling of not living up to that image and to the expectation, or not living up to how their mom behaves and provides for the family, right? So be aware of that in young Latino women as well. We also now start to look more at social determinants of health and how those are, again, potentially marginalizing, right? When we talk about policies, institutions, and daily interactions. Societal, we definitely have to see racism as a huge aspect, but societal can be a lot of things, right? I think racism is the big one right now that speaks, but we could also add in here some of the restorative justice pieces, I'd say, and that may be straddling between community and societal, right? Because we're teaching young people to be more aware of not only social justice, but also their rights as young people of color, as United States citizens, and to know their rights as young people that are immigrating to this country as dreamers or otherwise, right? So really understanding that. So I don't want you to just kind of focus on racism as societal. For this model, it really points to that, and I think it's appropriate for, what we're doing with this series with you all here in Ventura County as well. So when we look at racism, we can talk about oppression, anti-immigration laws, policies. Racism definitely can lead to ethno-racial trauma in immigrant, Hispanic, and Latino communities, and it can really create this image. If you're a person that doesn't come from the Latino, Hispanic, or any group of color, and you may be coming from another race, white, Asian, Japanese, Korean, Chinese, any of those different cultures, you have to be really careful because just by you presenting different than a young person, especially in light of everything that's going on, right, you can really be at a deficit off the bat. So, and I'm saying that because I think you can be the most caring social worker, counselor, practitioner in the world, but just like our government continuously points out racialized features as factors of how to treat people and factors on policies and anti-immigration laws, you have to do your work to create a trusting relationship with young people of color, especially what we're talking about today for Latino youth and adolescent populations. Now we kind of start to introduce the concepts of distress, expressed through three concepts: cultural syndromes. We look at cultural idioms of distress, and we also look at cultural explanations. So cultural syndromes, cultural idioms of distress, and cultural explanations are ways that we kind of create a concept structure for people to be aware of, right? So cultural syndromes, groups of symptoms that occur among individuals in specific cultural groups, ataque de nervios, or attack of the nerves, is one example. Cultural idioms of distress, ways that symptoms are expressed which provide a collective and shared way of experiencing and talking about personal and social concerns. So when we see groups of people that have immigrated from the same part of the country, and we see that in communities, right, where there's clustering of people who have immigrated because they send those, word out to their peers that it's a safe community, there's access, there's, primarily it's about safety and being, safer in numbers, honestly, a lot of times. But there also can be communities that are very welcoming to the immigrant population, and when we see the sanctuary states that are receptive to having folks come to their communities, obviously that experience can also be shared and taught to others. Cultural explanations, so labels, attributions, or features of an explanatory model that indicate, again, recognized meaning or etiology of symptoms, illness, and distress. And you'll kind of see what those look like here in just a little bit. So give me 1 second. Okay, I just want to make sure where we are on the slides. So ataque de nervios, again, characterized by symptoms of intense emotional upset, anxiety, screaming, shouting, dissociative experiences, seizure-like or fainting episodes, maybe suicidal gestures, apacas, but absent in others, right? In terms of certain individuals, or maybe the experiences are the cause. And then mostly it occurs as a direct exposure to stressful events relating to the family. And these are some of the idiom kind of symptomatology physiologically that we see, right? Irritability, stomach disturbance, sleep difficulties, inability to concentrate, trembling, tingling sensations, and dizziness. Susto, and this is one that I would really draw your attention to, you know, from a perspective of you all looking at it from schools and community-based agencies, is susto, or attributed to being frightened or experiencing a frightening event that may cause, again, the way that it's explained culturally is the soul to leave the body. It kind of, you know, really gets the soul shaken up as well, and results in sickness, unhappiness, difficulty functioning in key roles, and maybe other somatic symptoms like we mentioned, physiological or somatic in nature. We definitely see that this is more prevalent for Latinos living in the US, from Mexico, Central America, and or South America. Mal de ojo is a consideration illness transmitted by making eye contact with someone. It is received through the eyes of the intended recipient. The instigator frequently conveys the victim child, and when the illness is passed, it heats the blood of the victim, causing multiple gastrointestinal problems. You know, my mom experienced this as a child, and reported that she went to several doctors and had a very high fever. And it comes through when people tend to covet a young child, and they're very kind of, oh my gosh, she's so beautiful, and kind of it creates, and there may be a certain aspect of envidia or jealousy as a part of things. So really, again, culturally, this may seem very far off to those of you that don't come from this cultural group, but as an explanation of an illness, we have to pay attention to this in order to maybe help somebody that may be more traditionally or culturally bound. Increasing protective factors is definitely something we want to do in order to reduce mental health symptoms and disorders. And we see two different types of protective factors: variable income level, peer group, adverse childhood experiences, unemployment, and the ones that don't change, which are typically, you know, genetic predisposition, and or again other mental health and or factors that increase potential health factors, right? Like diabetes and or heart disease that may be passed on, again, genetically. We definitely see religion and spirituality as being an important part of building protective factors. You don't have to be religious, you don't have to be spiritual as a provider or as a school-based personnel, social worker, counselor, but the people you may be serving, they may be. So be knowledgeable about those resources. It doesn't mean that you have to adopt a religion or be spiritual, but being aware of that and paying attention to that, and knowing that this may create a very respectful approach to traditional healing approaches, and really be able to create some intervention, and again, some cases of divine intervention when we talk about fatalism. Involve the family, be able to help them clarify roles and expectations, develop interpersonal relationships, because these are significant, and that's a part of it as far as starting at the interview process, being receptive and open, starting where the client is, and paying attention to some of the concepts that we're providing to you today. I think will definitely get you down the road. And then talk with the family. How do they view mental health? How are they seeing this in their experience, and have them describe it? Latino and Hispanic communities and populations are typically storytellers. Oral history is a huge component of our family, and is a huge component of, I think, another protective factor of the family, because it sends messages. Sometimes, though, we can see messages that may present misconceptions of ideas, especially when it comes to the United States, what therapy is and what it does to you, and maybe the scariness of it, right? We can help kind of dispel those myths as well. So sometimes it's correcting misinformation. But oral history is a huge protective factor for families, especially traditional families, because That's the way that families have come to protect themselves generationally through their experiences, and the experiences of immigration is through that history. They tell each other, this was my experience, this is what I went through. And young people take that on, and we see that a lot also with our Native American and indigenous communities. 500 years after colonization, still experiencing traumatic histories and traumatic stress disorder, if you will, for young people who they're 2 or 3 generations removed from that, but experiencing it nonetheless, right? Like it's real. So the role of family, I think we talked about this. Sometimes Latino families will have a stigma towards mental health. They will often turn more to community-based and less formal prior to doing a more formal referral or connection, and usually that'll come through a family friend or someone else. And then we start to really want to create familismo. You know, it's a value of putting the family at the forefront of well-being. And I think if you really are paying attention as a practitioner, that should be a real focus of your work, is to engage, you know, engage family since the beginning. We talk about respeto. So showing respect is definitely important in all cultures, and it's definitely pronounced in the Latino and Hispanic culture. They see a difference in status between professionals and non-professionals, and sometimes they'll take a passive sort of role in the treatment process until you really engage them and invite them and say, no, we really feel you're an important part of this process, right? Because typically in many communities we're working, when we talk about community-based or school-based, sometimes it's more of the medical model approach with client or patient care, where it's just the client in front of me, I'm working with their issues, that's what I'm doing, not really including all the other environmental and relational factors like we spoke about earlier. You know, be genuine, but with that, being warm and personal and showing interest can definitely engage and provide an increased therapeutic alliance. Personalismo, demonstrate sympathy or simpatias, kindness, and again, likelihood of compliance increases significantly when we're making things personal, when we're really getting to their level, and we're not treating people as though they're a number, kind of just getting them through, and we don't create a unique relationship, showing your interest and compassion. And then collectiveness, you know, this really shows community-based stuff, where a lot of group activity, responsibility for achievement is a shared concept, and really in communities that we're speaking about here, there's a sense of harmony when there's interdependence and there's a collectivism. When you come to the United States, in many communities, it starts to become a separative type of experience. And when you can create that in your school or your community, more of a familial, a collective type of atmosphere, following the work of Paulo Freire, right? Those of you that are very aware of this work and have done, you know, equity and anti-racism, look at Pedagogy of the Oppressed. And I think that would be a really good primer and start for folks that are just getting into this work to really see how this may help them in understanding what this term collectiveness looks like. The images that we show students and kids matter. And the internet and Facebook and Twitter and Snapchat are flooded with all of these different images. And I can't stress this enough, folks. We have to be able to counter these images through our behaviors, through our interaction, through our connectedness, through our respeto, right? Our respect of the Latino and Hispanic communities that are really experiencing things when we talk about anti-immigration sentiments at a very high level. Decisions today impact long-term outcomes, right? And that relates back to ACEs. Adverse childhood experiences that young people are experiencing now in these detention camps and being separated from their parents are just exacerbating the immigration experience and the societal messages and the governmental messages that are being sent currently. So we have to be compassionate. Ethically, as counselors and social workers, we have a responsibility to put our biases aside, to start to pay attention, to start to recognize our privilege and our maybe at times inability to connect to people that are different than us. we have to address that, and we have to do critical self-reflection in that work. And that's our ethical duty based on ethics and code of conducts within our professions. That shouldn't be anything that we, push back on or don't see as important. Those of you that are aware, and any federal entity that receives federal dollars is required. Now, I know this administration is not going to support that or enforce it, but we have to ethically enforce that as people of color who are in positions to make decisions, to influence those circles of influence that you have, by saying we have class standards, CLAS, right? Cultural linguistic standards that are required of us if we're serving Latino, Hispanic, Chinese, Japanese, whatever cultural group you're addressing is other than a language that they speak is other than English. We have to provide services that are appropriate in that, the best that we can, right? If we can't have those, if we don't have those folks in our communities or our agencies or schools, we have to contract for those services. Class standards demand that of us. So the next several slides, and I think that'll take us to a perfect wrap up here, are the institutions, school personnel, and providers may exacerbate mental health symptoms in Latino students if we're not paying attention. So the next several slides are a primer for considering our next presentation, which is going to be restorative justice. And looking at that, a huge barrier that we see that is creating an access barrier is access to resources in general, but more specifically, a lack of culturally appropriate resources, a lack of linguistically appropriate resources in the community. Depending on your status, whether resources exist or safe resources exist. And I'll give you a real quick example. I was fortunate enough after 9/11 to spend about 3 months in New York City, and I was downtown on Canal Street at the Red Cross Center. And at that point, we had people waiting in line for 24 to 48 hours in freezing weather during that time, right after September. So I was there October, November, December, and we had people outside. A lot of people in my site there for Red Cross were Spanish-speaking community or people of color who were displaced because of the explosions, in New York. Now, we had to work really quickly, and what was a very initial sign for me, and I know all of you that speak Spanish are going to kind of nod your head and say, yeah, that's who I am. Once families spread the word, just like these clients that we experienced in New York spread the word that I was able to speak Spanish, and one of their National Guardsmen there was able to speak Spanish, we saw a huge increase in Spanish-speaking families and members who were needing FEMA assistance come into our center. Because one, they knew that we were going to treat them with respect and integrity, and two, we spoke the language. So they saw an access point. We had to give out flyers in their language and have them take them back to their community and share them with others. So there's ways that I know that you all are doing that. In California, I know many agencies and schools are very, very progressive in this way. So I just use those as examples. So what I say is invite families to be involved in their language, right? Engage with them. Stigma around accessing help and support is something we definitely have to address. And then systemic or structural barriers that set a tone of either you're welcome here or you're not, right? Each one of you, even whether you're Hispanic or Latino or not, as a human being, each one of you, as you go into a space, which we call spatiality awareness, right? When you go into a space, you know if you're welcome in that space or you're not welcome in that space. You know if you're othered in that space or if you're felt and you're made to be comfortable in that space, right? So understand that of your agency and of your school. Do you show that you're welcoming to immigrants? Do you show that you're welcoming to people of color? Or is there messages, or is there signs, are there posters of only one certain dominant group? Are there only advertisements in the dominant language? Are there events that formally, when we talk about Hispanic or other cultural groups that do and I don't want to offend anybody, but we do the ghetto tour, right? Where we give people a tour of all the cultural stuff. Let's have a taco night for Hispanic and Latinos, right? And those things can be very racial. They can cause discrimination experiences for people, right? Let's do things more so like inviting someone from the community that comes from Latino community or populations to come and give a speech about integration and welcomeness, and invite those sort of speakers, right? Have a staff that reflects the populations that you're serving whenever possible. All of those are addressing systemic structural barriers in our strategies. So we look at four, and I have about about 5 minutes, and I'll wrap this up. Implicit bias, language matters, social and institutional discourse, racial microaggressions, and explicit racism, right? And like I said earlier, institutions, school personnel, and providers may exacerbate these if we're not paying attention to those. So implicit bias refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in typically an unconscious manner. So these are typically the things that we favor or look at unfavorable. These may be taught to us as young people, as kids, from our parents, our grandparents, our family. A lot of times are the culprits initially, I'm sorry to say, that teach a certain racist tone or separative tone about groups. And then the unconscious bias, again, much of our behavior, folks, is driven by learned stereotypes. Until we engage with people of a different race or culture than us and experience them for ourselves, we will typically defer to what we call hidden bias or implicit bias or learned stereotypes or behaviors that we were growing up with. This is huge to me. Language matters. So typically when you look at documents, policies, practices, you can see if there's a us versus them type of language. And this is significant because this is a history, there's a history with divide and conquer, right? When it comes to us and them language, discourse and rhetoric that will continue to oppress people, or those, when we talk about those people versus us, right? Or them versus us. What about all inclusive? We, right? Us, and solely using that. Examples of the highest office in our land, and I don't want to get political by any means, because our message and our approach through the MHTTC is one of collaborativeness, one of let's have the tough conversations. And I know for this conversation in particular, it's kind of a one-way discussion to kind of lay the framework, but we hope that, and I'll visit with Daisy about this, but I would really want to engage those of you that feel you want to be a part of that, is to really have a follow-up session after these 3 trainings and just have a conversation around some of these issues, around the rhetoric and the fact that language matters. And when the person in the highest office refers to people who are immigrating to our country to seek peace as criminals, as illegal aliens, illegal immigrants, violent protesters versus fine people, right? We have to understand that that impacts young Latino people, and it impacts their ability to connect with you if these are similar things that are going on within your institution. So very similar to the language matters, us versus them, theirs versus ours. The order of racial groups and documents matter. Some racial groups are left off of documents and policies, and there is sometimes an othering that goes on within policies or legal discourse. And typically when that happens in policy that then becomes law, people of color are placed within certain groups and they're in a certain hierarchy, if you will. And this includes with schools, right? Because we see social institutions creating AP students versus general ed students versus special education students. These are forms of profiling, folks. And if you don't see that, you definitely have to look a little bit closer. And I'm not saying that there's not Hispanic Latino students in AP classes, because I know they can definitely do that, and they have those capabilities. But predominantly, let's look at those. What are the groups of people that are predominantly in those classes? What are the groups of people that are predominantly doing the dual programs, right, through taking courses as juniors and seniors in high school, in college, and really developing that? Most times it's the most dominant group in your community, whichever that is. Explicit racism, and you know, we'll talk more about this next week. I want to really wrap up and give you guys you know, at least the last 10 minutes or so to ask any questions if you have them. We definitely have to look at racial profiling and discrimination. broken window policing, all instances of misconduct, especially in schools nowadays, are referred to probation of the courts or the courts. There's a zero tolerance, right? Whereas schools used to deal with infractions of behavior within the school. How many of you, had to go to in-school suspension, right? Or go to after-school program because you broke a rule and they had you address it, right? Nowadays, they're sending people to probation. They're sending people to jail. And a lot of times that's young people of color. So when we talk about this school to prison pipeline, these are the policies that impact young Latino communities and young people of color in other communities as well. Academic tracking or policing in schools nowadays. Nowadays we have police officers with guns and all the hardware that they need to take down a 12, 13, 14, 16, 17-year-old kid, right? So we just want to be aware and I think have an understanding of that. And we'll talk more about this next week as we get into the second part of this. And then racial microaggressions. When a person of color or Latino or Hispanic person talks and they're from the United States, or maybe they immigrated 2 or 3 years ago, but making comments like "you speak well" or "where are you from," assuming that they're not from this country. I've had that, and I was born in this country, and I get that at presentations. Or sometimes people ask me, "Well, you present very well," and I said, "Well, I should. I spent 10 years in higher education and a lot of money to be able to do this, to change my accent and be able to speak more appropriately when I need to." But believe me, it comes out, and it's there, right? It's still there. And then talking behind the student's back to other professionals or students about racial identifiers or stereotypes, but unwilling to speak to the student, right? Passing notes to other dominant groups or your peers when a person of color is speaking, or doing side chat, right? Sometimes those can be racial microaggressions, and we're not aware of that, especially if they are specifically to talk about the person of color that is in front of you or that you're working with. And in summary, there's 8 considerations that we want you to think about. Investigate. First, evaluate racial climate. Get a sense in your school, your community-based agency. What does this look like? Explicitly and implicit bias are extremely important when we talk about structural racism and community-based agency awareness, right? The organizational development. Investigate and keep a track record or a website, a spreadsheet. Track it in some way, but keep reports of discrimination and track that. Identify norms that ignore racism, address those. Establish monitoring systems, like I said to bullet 2 there, and then give critical feedback about practices to practitioners. And lastly, we should promote racial diversity, implement, evaluate training like you all are doing here, and I'm so thankful. Thank you for having me and coming and talking with you guys as we get into the next couple of weeks. I'll share more with you all my experiences and history as well, more than just the introduction. But a huge component of this is that we have to do critical self-reflection, right? We have to be able to look at ourselves and pay attention to these implicit biases that may be a part of how we're presenting racial discrimination and or bias as providers. So with that, I thank you. I appreciate you all attending today. I'm going to go ahead and turn it over to Cindy, who may have some follow-up questions for you all. We may be able to take a few questions here, and while I'm doing that, I'm going to go ahead and send you all my email address. And you're more than welcome to email me any questions if we don't get to you today, or if you're a little shy and don't want to ask questions over the webinar, we can get back with you as well. And the last thing that I want to say is, please reach out to us. Those of you that are from other communities, if you want a more specialized, and we can take any one of these different sections that we've kind of covered here in a short time, right? We've introduced a lot to you today. And I apologize that there's not a little bit more interaction, with this presentation, but we have to at least create a baseline of information and definitions and so forth so that we can continue the dialogue. And again, I really hope, and if Daisy's on this training today, perhaps we can schedule a follow-up webinar where we just have a conversation about addressing racism, about addressing discrimination, and increasing your awareness of how to pay attention to those things a little bit more. So with that, I just sent you all my email address, and I will go ahead and turn it back to Cindy.
Thank you, Dr. Romero. I wanted to remind everybody, you can submit questions through the question box. It might look like a shot on your end. So on the panel, you have a tab that says questions. That's where you would submit your questions. And with that said, I have one already here, and it says, do you think proximity of homeland has an impact on the rate of acculturation?
The impact of homeland security on the rate of acculturation, absolutely. And I think that also impacts dramatically young people and Latino families accessing services again, right? Whenever there's a climate shift nationally and even in our own communities, I know in New Mexico, our law enforcement sheriff's office invited immigration and invited the federal government into our community, and it's been really impactful to communities of color, where we were seeing them starting to come to more services and reach out. We're starting to see more isolation again, and less reports of domestic violence, less 911 calls, etc. So absolutely, I would say that's a huge impact.
Awesome, thank you, Rocky. We don't have any more questions as of now.
Right.
You want to wait a minute or so to see if someone else has a question?
Yeah, sure. And then, I'll just kind of end, and after if there's any other questions, we can end there. But I just want to, again, say thank you to Daisy and Ventura County Department of Education for reaching out to the MHTTC. Please, our information is here, our website. And thank you to Ivis and Angel, Dr. Carrion and Angel Casillas, of course, Dr. Miranda, Daris, and all the folks that reviewed our presentation and really gave us some good feedback. I'm really thankful that Daisy invited us. And for those of you community-based agencies, or if you're attending from another county or another part of California, that you may have a need for a more specialized or even a replay of this presentation, please reach out to the website and email address there, and we will definitely reach out to you and schedule it. Those are take advantage. SAMHSA pays for this grant to provide services and training and technical assistance. So we're here to support you all. And with that, if there's any other questions, we'll take those. If not, we can go ahead and end for today, if that's okay.
No, we don't have more questions. We do have a couple of comments and feedback thanking you and saying that it was a great presentation.
Awesome.
So yeah, that's all we got. I think.
All right.
Yeah.
Well, thank you, Cindy. Take care.
Take care, everybody. Have a great day.
Thanks, Cindy. We'll see you soon. Bye.